Behaviour is really complex. It is hard to change. We're all out there doing the good fight. We want to get things better for our patients, our service users, our clients. But it is hard. And therefore, if we try and simplify it and pin it on evidence and theory as much as possible, it can most definitely help us. So just a reminder, what we're all trying to do all the time is we're either trying to change or influence a behaviour. Whether that's trying to get people to think about switching or stopping smoking, improving their diet, getting more active, brushing teeth, engaging with our communities. Immunizations came up there as well. Really what we're trying to get to the root of is, how do I change this behaviour, or how do I influence somebody to make a change? And therefore, it's really useful to go back to the rainbow model when we start to think about the wider determinants of health, and we're trying to frame how much behaviour is influence. Now, I know on this call it's a public health audience, so I'm sure most of you have all come across this. It's a really helpful model by Dahlgren and Whitehead, which has been in play for over 30 years. And of course, at the middle, we've got our biological factors we're born with that we can't do a great deal about. That, of course, hugely impacts our health. And as we traverse those layers, we see different things coming into play, like the lifestyle we lead, unemployment, access to water, to nutritious food, healthcare, our general cultural and socio-economic environment around us. And if I got you to look at that list at the bottom, to say, well, what impact as a percentage does environment have on your outcomes with health or healthcare or these other things? And I'll pull those percentages up for you. So, for example, your genetics play 30% in that, your environment about 5%. If I was to say to you, well, what do your behaviours play with that? It'll be really interesting to hear from you. Maybe you can drop it into the chat, which I can't see. So Russell and JP, maybe you could help me out and let me know what sort of numbers people are dropping in. Thank you. So the flavour is that it's higher than what I put up, and actually you're spot on, it's 40%. And something here that always strikes me is, of course, we need to get healthcare right. We've got a new government now, so we'll see what they come up with. But it really strikes me when I look at these stats and say, wow, 10% impact is healthcare, but 40% is behaviours, which is why it always comes back to public health and what we're doing, not just for people that we know have got diagnoses, but what are we doing in the preventative space? So what's a behaviour? Not in any way meaning to patronise anyone, but I when I start out with things, often can sit there for a while and think, hang on, I've been going on about an outcome. That's what I want to achieve overall. And it's really important, because the number of projects sometimes that I see where they're all very well intended, but actually the focus when they're deciding what to do is they're still looking at an outcome. Now, I put a few things on the screen there, just to sort of illustrate the point that, if you took a quick look at these all seem like very well intended things to work on. But for example, injury at work is an outcome. So if we're talking about how do we decrease injury at work, you want to start to look at the range of behaviours that people are engaging in that cause an injury at work. So I would always say, always come back when you've started, we always start with outcomes, because there's a decision made about what needs to change. But remember, that needs to then be broken down into a list of target behaviours, because that's where you're actually going to create the activity that moves that outcome. So just a little bit of a reminder about always break it down to a range of target behaviours and then make choices. So when we're thinking about the applicability, within public health, population health, we've got our different layers of prevention, which sort of came out in that rainbow model that I showed you as well. But essentially, and I can't probably hammer this point enough, we really need those evidence-based interventions, whether we're talking about one-to-one interactions in a consulting room to wider public health campaigns. And we have to absolutely start moving away from this Islagiat, which is, it sounded like a good idea at the time. And I'm sure lots of you, and this is something that when I came across it did actually make me giggle. It was in my master's, and all the tutors would say all the time, it's amazing how much of this you'll see. And suddenly I started noticing it everywhere, that we're trudging along sometimes doing what was always done, because intuitively it just seemed like a good idea, like an expensive poster campaign on the back of a bus telling us to eat more fruit. Well, actually, what was the evidence base? What was it telling you about the previous campaigns before it was decided that it was worth the money or the resource? And did it actually create the behaviour change you wanted to create? So just a little bit of a reminder there about how we need to start moving more towards that evidence base. So that's all very well, but what do we do about it? So I'm going to talk to you a little bit about this model called COM-B. And again, I'm sure lots of you use this, have come across it. The reason why we see this crop up a lot in public health, in healthcare, in social care, is it's actually the behavioural model with the most evidence. There's lots of research that's been done within health, whether we're looking at things around prescribing, around infection control, around vaccinations, and essentially why this works so well is these three, what we call determinants of behaviour: capability, opportunity, motivation, that actually cover a huge breadth of determinants of behaviour. And as you can see, they interplay with each other to determine a behaviour. Now, when I say that, what I mean is capability. If we say psychological capability is how much knowledge or understanding you have about something, if you know that something perhaps is really good for you, that might increase your motivation to do it. You see lots of positive outcomes, that increases your motivation more, so it impacts. So these are really useful to understand as a system. And these can be broken down with two sections in each. So with capability, I talked about psychological capability, which is having the knowledge to understand why you would engage in a behavior. Physical capability is actually having the skill set. So for example, I want to go off and start playing tennis. Do I actually know how to do it? As a, off the top of my head example. Motivation. Now we can break this down into automatic and reflective. Automatic motivation are emotional responses and habits. You're not thinking about it too much, you're just doing it. Whereas reflective motivation goes a bit further as a cognitive process from just psychological capability, because what you're doing is, with that knowledge, you're juggling that information, the pros and cons, what those different outcomes mean, and then you're making a decision based on that. An opportunity we describe as anything external to a person that determines behavior, and we break it down into physical and social. So physical opportunity could be resources and time. So for example, if we're trying to think about encouraging physical activity, do you actually have a space near you that is available, easy to access and safe for you to walk in, as an example? Social opportunities, again, are things that dictate our behaviours, such as social norms. So the influential people and messages around you that you are actually going to listen to, what are they saying? What's the cultural norm within which you're in that's going to influence your behaviour? Now, to give you an example, I had to do an assignment during my master's. So it was hypothetical. And because my background is primary care, I pulled apart this behaviour and used COM-B for it. But it's just an example. You can extrapolate this to anything you're doing. So what I wanted to work on as an outcome is, we've got a lot of people over 65. Generally, it's a national problem, but certainly in Southeast London, who turn up to hospital because they're having adverse drug reactions and side effects to drugs like ibuprofen. The reason it happens more commonly in older people is because they're more susceptible. So I wanted to pull this apart and say, right, well, that's the outcome. What are the behaviours? And I looked at a few different things. And essentially, the behaviour that I decided on is getting the prescribers in primary care, because about 80% of prescriptions are handed out in primary care as opposed to secondary. Getting those prescribers, so predominantly GPs, to prescribe paracetamol first line instead of NSAIDs, which are ibuprofen and its family drugs. Now, as a target behaviour, I had a list. So we had things like, do we, for example, restrict over-the-counter sale of ibuprofen? Now that goes much deeper into legislation, but decided actually that's quite draconian. It would probably not do much for a pharmacist client relationship. Plus, we couldn't really find a way to appropriately measure that, as an example. So that wouldn't be as good. So the point that I was making is, you'll find lots of target behaviours that will come up, and you will decide which to work on depending on how cost effective it is. Is it really going to achieve the impact you want? Can you measure the change? So the reason I went for this is we can easily measure it by prescribing data. We're likely to affect behaviour change, and we're going to create a big impact with decreasing adverse reactions in this population, as opposed to doing something more like restricting over-the-counter sales, or by saying to GPs, just absolutely refuse that prescription, because ibuprofen does have a place in therapy and it can be effective for certain things. So, and I apologize for the way this looks. I've tried to enlarge it as much as possible. So when I ran this through the COMBI model, in terms of, I looked at all of the different things, the capability, the opportunity, the motivation. So in terms of physical capability, we said, right, well, for GPs to prescribe, they need a way to do it, a handwritten prescription or electronic. Is there a need for change? No, they already do this. In terms of psychological capability, GPs need to understand the outcomes of the risks and the adverse drug reactions. So is there a need for change? Yes, although very conscious, we've got lots of education, delivery and guidance already available for this, and we're not quite seeing the change we want. In terms of physical opportunity, GPs do need the time to discuss with their patients why they recommend paracetamol over ibuprofen. Is there a need for change? Yes, absolutely. In terms of social opportunity, could we actually start sending messages to GPs telling them how well colleagues are doing in reducing their prescribing of ibuprofen for this group? And we know that modelling and social norms are a really powerful changer of behaviour. So we said, well, yeah, there could be place for change here. And then we move to the last part, which is motivation, which is GPs need to actually develop the intention once they weigh it up to want to prescribe their over 65 patients less of this and more paracetamol, and automatic motivation. So they just do it habitually. They just automatically prescribe paracetamol 65 for pain. Is there a need for change? Absolutely not, because we need to be really careful here. We still need there to be a reflective process. Indications, someone could be allergic to liver condition, which means they can't take it. So we absolutely don't want to get into the stage where we make it automatic. So when we ran it through this model, we said, well, the behavioural diagnosis here is we could look at psychological capability, social and physical opportunity, and reflective motivation. And then what do we do with that? So we know what we can work on. So here is where we can use something called the behaviour change wheel. Now, this is a really useful bit of kit, and essentially it's got the COMBI model at its core. You can see there it's all in green. And what this has done is it's a combination of 19 evidence-based behaviour change frameworks all pulled into this one behaviour change wheel. And essentially what it's done is it tells you the outer circle, which is in red, what possible interventions you could go for, and the grey part tells you the different policy categories you could look at. So again, I'm taking you on this journey of how I ran this through this model. So I then used the behaviour change wheel. And essentially what I settled on once I ran it through was, well, we could definitely look at improving education of GPs about the adverse outcomes. But maybe instead of the standard just talk to you in an educational setting, let's think about how we deliver this intervention differently. And this is the great thing about the behaviour change wheel, is it introduces things to you that perhaps you hadn't necessarily thought of. So something came up around a BCT is a behaviour change technique on giving feedback on outcomes of behaviour. So we could say, this is your individual prescribing data for your surgery. This is the number of your patients age over 65 who've had an adverse drug reaction because of ibuprofen. This amount then ended up in hospital with a bleed or an ulcer or a hemorrhagic, a bleeding type stroke. And that's very, very powerful as a motivator. We can also start to use prompts and cues. So we've got software that we use in GP surgeries already that's already paid for, so very cost effective, and we can design the messages. So for example, with the social opportunity, a message can come up when you're prescribing ibuprofen and it triggers something because the patient's over 65 and it says, your local GP colleagues have reduced their prescribing in this cohort of patient by 20% in the last 3 months. We suggest you prescribe paracetamol if safe. So that's the kind of nature of messaging you can use, and that falls into environmental restructuring. And that also picks up on the social opportunity there. So we're kind of covering that all with that messaging, the environmental restructuring and also the modelling. And we've got a really good way to measure it. So we can see the impact because we look at the prescribing data. So as kind of an example, as I said, of how something that starts as an outcome, which is we really need to get these, our over 65s who are turning up having lots of unnecessary bleeding from their stomach and ulcers, really dangerous situation. How do we improve the outcome? Well, what are the target behaviours? Let's run it through COMBI, then let's run it through the behaviour change wheel. So this is an example of how you could do that, and you can extrapolate that to whatever public health campaigns or projects you're doing. So just a few take homes. effective interventions have to be based on sound theory. The Medical Research Council tells us this. We just need to go forward with it. We are trying to change behaviours or influence most of the time. They're complex, they're not one-dimensional, but you break it down into a list of targets and pick the most effective one. Really define that behaviour, and then think about using an evidence-based model such as COM-B. The great thing with COM-B is it then takes you to the behaviour change wheel that can support intervention design. It feels a bit overwhelming. I'm very conscious of that when I've just taken you through that. But once you use it once or twice, actually you can see the real benefit, and you don't need a sort of big complex organization to come in and do this for you. There's a really stepwise way of doing it, and I was sort of surprised with actually when we're just following the steps that it can be relatively straightforward, because what you're doing at the beginning is you're making it as simple as possible because it forces you to do that. So that's my other slight tip. Don't get overwhelmed by it. It's very possible to do. And I'm going to stop there.